Well, welcome back from the break. It's now my honor to introduce the second half of our webinar this morning, afternoon, by introducing my co-moderator, Dr. Kristine Erlandson, who is a professor of medicine in the Division of Infectious Diseases at the University of Colorado. And Dr. Erlandson has over 15 years of experience in studying the impact of infectious diseases on aging. Her research and clinical care are both focused on maximizing the health span among people with HIV, and it spans the translational spectrum from mechanistic studies to interventional studies and understanding the ideal models for care delivery. And as infectious diseases trained physician with expertise in gerontology principles and epidemiology, she's also dedicated to mentoring the next generation of clinician scientists. So welcome again, Dr. Erlandson.
Thank you so much for the opportunity to talk a little bit more about frailty. My disclosures are listed here. And my goal after today is to be able to have you all be able to talk about the relevance of assessing frailty in the HIV clinic, list some specific ways, specific things to assess, as well as ways to incorporate frailty measures in clinical care, and then implement interventions to reverse or prevent progression of frailty. So to start, it seems like frailty has become a hot topic. Frailty is all the rage. There's headlines on articles that talk about why is everyone talking about frailty. Within the last year or two, frailty has now shown up in the Department of Health and Human Services guidelines for ART, mentioning the aging phenotypes like frailty. And the IDSA guidelines also now mention annual screening for frailty as a consideration in people aged 50 or older. And although they don't recommend a specific screening tool, they do comment that the frailty phenotype is one of the most commonly used tools. The European AIDS guidelines, or EACTS Clinical Society guidelines, go into even more detail. As you can see from this flow chart, they have a algorithm on how to assess frailty, what to do with certain scores, a detailed table on definitions and what tools to use that spans over 2 pages dedicated to frailty in their guidelines. And frailty is also assessed in many different cohorts across the US, Europe, Africa, and Asia, so that we have a much better idea of how often frailty is occurring in people with HIV. So what is frailty? Why are we even spending time talking about this? As Roger mentioned in the initial presentation, we can kind of think about frailty when we see 2 different people of the same age and they just look so different. So for example, these 2 gentlemen, the one on the left and the one on the right, are both 80 years old. The one on the left may be in a skilled rehab facility, requires a walker to ambulate, whereas the one on the right is out running marathons. And clearly these 2 people don't appear to be the same chronologic age. So what is it that's different about these, and how does frailty help to explain some of the vulnerability that we might see that differs between these 2 people? So frailty can be defined by a decline in multiple physiologic systems that leads to a vulnerability with stressors. This can include physical vulnerability, psychosocial vulnerability, a cognitive vulnerability, but we can also think about it as someone gets hospitalized. Say they get pneumonia, they didn't get their influenza shot, they end up in the hospital with severe pneumonia. The gentleman that was in the picture on the left that was already in a skilled nursing facility has a pretty rapid decline during that hospital stay, and it takes a lot to get him to go back to the prior level of function. Whereas the gentleman on the right may bounce back pretty quickly, may have a short hospital stay, and doesn't really impact his long-term function. So that vulnerability on how someone might respond to a stressor can reflect what we mean by frailty. Frailty can be defined by lots of different definitions. Probably the most common is the phenotypic definition, or the Fried frailty phenotype, or an index, or the Rockwood Frailty Index is the one that's most commonly used, that's more of a reflection of multi-system decline. So if you look at the table on the right, the Fried frailty phenotype is really this phenotype. So what do we see when we look at someone? How do we describe their frailty? The initial definition was developed using 5 different components, and we have different cut points for if someone has slow gait, if they have weak grip, low levels of activity, fatigue, or weight loss. And then there's specific criteria. If someone doesn't have any of these impairments, they're considered robust or non-frail. If they have impairment in 2 of these categories or 1 of these categories, they're considered pre-frail. And then if they have impairment in 3 or more, they're considered frail. The Fried frailty phenotype has been used in multiple different cohorts in people with HIV, and we have a pretty good estimate on the prevalence. It does take about 10 to 15 minutes to assess, so it's a little bit challenging to implicate in some clinical settings, and it's often done prospectively as we're looking at how fast can someone walk, what's their grip strength, has their weight changed. The Rockwood Frailty Index, on the other hand, is just essentially the idea that the more things that someone has wrong, the more likely that they're frail. And this is developed using several different variables, usually at least 30 to 40 different variables that reflect different organ systems. So we could potentially include hearing, cognitive, renal function, assessment of many different components. These are variables that have specific criteria, so they increase with age, but they're not ubiquitous with age. So we wouldn't use age as a variable within this index. And then they're associated with poor health status. This is looked at as an index, so the number of variables that are impaired over the number of variables that are assessed. And then that number ranges from 0 to 1. And usually a cut point of about 0.4 is considered frail. So if someone has about 40% of the things that are assessed are impaired, then they're considered frail. The benefit for the frailty index is that this can be embedded into a healthcare system. It's different for each system, so I could develop a frailty index at my site that may be different than a frailty index at your site. But once that's embedded in my system, it can be pretty quick, and I could go back and look at this retrospectively. But there really are hundreds of different frailty assessments that have been published in the literature. The VAX index, or the Veterans Aging Cohort Study, has been developed in the Veterans cohort. I've included the link here to a calculator, but this kind of approximates something similar to the frailty index, where it's looking at impairment in different organ systems, although it's a score instead of that ratio. The CENIX cohort, one of the HIV research cohorts based in clinical care, has developed a frailty phenotype-like index that uses existing data from questionnaires that are assessed as part of clinical visits. There's a Frail scale that looks at questions that are approximating the frailty phenotype, and then several other tools, including those that have been developed using billing claims-based codes and trying to approximate a frailty index. One of the more popular indices that really came about and kind of raised awareness was during COVID, the clinical frailty scale. And this was used in some healthcare systems to kind of help to decide who might be appropriate for intensive care or not. So this is really just an eyeball test of a provider would look at a patient and say they are very fit, robust, they exercise regularly, and so they have a 1 versus someone who might be moderately frail and need help across all activities who might fall into a 5 or 6. There are some specific recommendations on how to make this a bit more objective, but it really is a subjective assessment of how I feel this patient looks. So why do we care about frailty and why should we measure it? Well, we know that frailty is associated with many different poor outcomes, including increased morbidity and mortality, increased risk of falls, fractures, lower quality of life, loneliness, dementia, and so on. Frailty also can drastically increase healthcare costs, but most importantly, it can help us think about how we're delivering patient-centered care. So I'll come back to that a little bit more in the subsequent slides. Obviously, we're probably talking about this in today's presentation because frailty does seem to occur more commonly, as well as earlier in people with compared to without HIV. This is data in the figure on the left that's from the Amsterdam a cohort in Amsterdam looking at people with and without HIV who have similar risk factors. You can see the group without HIV are in the left hand bars, and those with HIV are in the right hand bars. And the frailty shown in the darker gray color, kind of that moderate gray color, is pre-frailty. And if you look across all of these age ranges, even up to greater than 65, there's an earlier occurrence of frailty, as well as a greater prevalence of frailty in people with HIV compared to people without HIV, regardless of the age range. So this is certainly a concern in people with HIV. We seem to see an earlier occurrence and a high prevalence, or higher prevalence than those without HIV. The figure on the right shows some data from a recent systematic review and meta-analysis that looked at the prevalence of frailty in multiple different cohorts, ranging anywhere from about age 40 to up to greater than 70 years of age. And you can see the variety of frailty prevalences across different cohorts. I outlined the red bar here that shows a prevalence of 5%, and then the red bar on the left that shows the prevalence of 20%. And this gray bar in the middle is looking at a prevalence of 10%. So probably a prevalence of 5 to maybe 10% at the most is what we would see in most clinics. So although we hear a lot about frailty, it really isn't occurring that commonly in people with HIV, probably in the 5 to 10% range, maybe a bit higher in our older populations. I will note that several of these studies that have much higher prevalences are generally in populations where people are not on antiretroviral therapy or are over age 70. So not particularly common, particularly in our 50 and older population. I'll just briefly talk about some of the factors that we think may increase the risk of frailty, many of which were covered in the earlier talk by Dr. Corley when we think of some of these hallmarks of aging. We also know there's a lot of mental, behavioral, and risk factors that can contribute to frailty, such as physical activity, substance use, depression. There's social demographic factors such as income, ethnicity, and education that can contribute to frailty, and then many different modifiers that may impact the progression and how quickly someone moves from a robust state to a pre-frail state to a frail state, including alterations in inflammation, hormones, and different comorbid burden, all of which we know probably occur more commonly in people with HIV. So with this context, we perhaps I convinced you that you should assess frailty in your clinic, but how do you decide what tool to use? What are we asking? I think this tool that recently came out that's through the eFrailty website that I included the link here kind of helps us to take a step back and think, why are we measuring frailty? So even though the guidelines tell us to do it, what are we hoping to accomplish by assessing frailty? So are we looking for a screening or a brief risk assessment that maybe we could say, here's this patient that is likely or maybe is at risk for frailty, and I can intervene to hopefully prevent their frailty? Am I assessing frailty as part of a much more comprehensive care plan, maybe a geriatric assessment where I'm having an hour, 2-hour visit with someone to really understand what all their risks are and help them care plan? Or perhaps I'm just assessing something quick before they go into surgery, and I want to know, are they at high risk of having a decline after surgery, that maybe they need to do physical therapy or have some sort of risk modification before they go into a surgery? So if you go through this tool, it'll give you some suggestions of kind of quick assessments or longer assessments, and really think about what we're asking when we try to understand if someone's frail. I think another big component we think of is this a tool that I could actually implement in my clinic that's meaningful? And I went through with a recent student and we thought about lots of different assessments that we could do in the clinic and really how pragmatic are these? Are these assessments that mean something to a patient and a provider? Are they assessments that could be done with reasonable burden to the clinic or with reasonably low burden to the clinic? Are they assessments that actually have something that's actionable so I can give recommendations to a patient on what we should do with this? And are these assessments sensitive to change? And we summarized some of the different frailty assessments, many of which I mentioned. Yellow kind of indicating probably in between, green being this is quite pragmatic, and red being this really isn't pragmatic. And these are our opinions and thoughts from the literature, but you can sense some of these measures certainly are more pragmatic than others. The Fried frailty phenotype, which I mentioned, probably the component that's not pragmatic is just the time that's required. But if we're doing a comprehensive assessment, that may not be an issue. So just some considerations as to what tool might fit with what you're trying to evaluate. What did the EACTS guidelines say? Well, I think this tool is actually really helpful that they've included in their guidelines. And they provide a recommendation for 4 options for brief assessments that could be done in the context of trying to screen for frailty on an annual basis. They suggest the gait speed, which is just a 4-meter walk, essentially across the room. Almost could be done in the exam room for usual gait speed. Short physical performance battery, which is a composite score of balance, time to rise from a chair, or the 4-meter walk time. The Frail scale, which was a brief questionnaire that includes questions from the Fried frailty phenotype, or the clinical Frail scale, which was that eyeball test. They have a nice table that provides some different considerations of each of these tools. And then they specifically go through an algorithm, really showing how these items might be actionable and how we might implement these in practice. So if someone has a gait speed or a cutoff score on one of these other assessments in a certain range, then we might consider them to be frail and refer them to a more detailed frailty assessment at that point that might be much longer, and then think about interventions for frailty, which I'll talk about a bit more. But I'd like to make a plug for one of the recommendations that the EACS guidelines recommends, which is gait speed. I think gait speed is an incredibly useful tool that can be done in really less than a minute, and probably more like 10 seconds in many clinical settings. It's strongly associated with mortality. This is a figure from gait speed and association with mortality in the general population. If we look at someone who's 65 years of age and walking fairly briskly, 1.6 meters per second, just again on that short 4-meter walking course, they probably have over 40 years of life left. So this is a really healthy person. This is that person that was in the figure on the right. In comparison, if we look at what the EX guidelines had as their cutoff of a gait speed of 0.8 meters per second, that person maybe has around 20 years of life left. So just this very brief assessment can really give us a good window into how healthy this person is and maybe how aggressive or not aggressive we need to be with their care. Gait speed is a major predictor of independence. It's associated with falls, fractures, and different comorbidities, including cardiovascular disease and diabetes, both in people with HIV and as well as in the general population. So we also looked at some of these measures. I showed this table earlier, but looking at some other measures that are potentially more pragmatic, that are just doing very brief assessments of physical function measures, many of which were included in the EACS guidelines. So gait speed, we felt was one of the most pragmatic measures. It can be done quickly. We can have specific cutoff scores that we can use to refer people to physical therapy or to different interventions if needed. We can improve it. It has objective improvements after training or rehabilitation, and it's sensitive to changes over time. One of the components of the short physical performance battery is just time to rise up from a chair. And you can imagine this can be quite meaningful to a patient. Can they get up out of a chair without using their arms? Also probably quite pragmatic, although doesn't have quite as much data as to implications as gait speed does. Grip strength is something we see quite a bit in the general geriatric literature. The only kind of downside to having a grip strength measure is it is impacted quite a bit by arthritis in the hand, and then you have to have a dynamometer available in your clinic to assess this, which can be a barrier in some HIV clinics. And then the short physical performance battery score that the EX guidelines recommended, also a great assessment, but it probably takes more like 5 to 10 minutes. So when you're thinking about all of these assessments, I'd say probably the most important thing is what works best in your clinic setting. What can you see actually happening? What's feasible in your setting? What if you have time for a 10-minute assessment, certainly consider some. If you really have time for less than a minute, then what can you make work in your setting? And again, considering some of these pragmatic measures as to what might be responsive, where can we detect changes, I think are also quite important. So just to give an example, I worked on a project with one of our geriatricians in clinic, and we really wanted to see, can we get gait speed as something in our clinic? This is a HIV clinic. We see patients with other infectious diseases as well, but we really focused on trying to implement gait speed in our HIV clinic. We started with just a stopwatch. I think we ordered a 10-pack of these on Amazon for about $10, so super cheap device, and measured several 4-meter courses on the floor throughout our clinic, kind of in different spots that we thought might be useful for the medical assistants as they're rooming patients. After several months, we also collaborated with a team at Georgia Tech and had this fancy laser device installed in our clinic. So you can see the blue button on the far left. The medical assistant would push this button, and then when a patient walks past this first kind of teal-colored laser device, it would start their watch or their time, and then they're walking to the other end of the hallway. And when they pass the second teal box, it would stop the timer, and they would have a time that pops up on this screen at the end. So somebody just walking past this device on the way to the room to go into their room, not adding an extra time for assessment, easily provides a gait speed on this monitor that then the medical assistant can put into the medical record. So we worked with our EPIC team, and they had recently done this in the seniors clinic, our geriatric clinic, outside of the HIV clinic, and we're able to get this installed into or inputted into EPIC as one of the flow charts. So it comes up just over or just underneath blood pressure, heart rate, oxygen, and we can have a yearly or a regular assessment of gait speed. And we do this actually with each visit, so not just if someone's coming in for a yearly visit, but essentially anytime they're in for a visit. It can trigger if someone's below a certain threshold. This is what was set by the seniors clinic at 0.8 or 0.6, which is probably a bit low for our population. But then we can also look at changes over time. Using this, we created, with the seniors clinic guidelines from what had worked in their setting, we created some workflows, had specific cutoffs similar to the EACS guidelines, where we said if someone had a gait speed of a certain number, we would recommend referrals to physical therapy or to community resources for exercise or potentially considering home health. So this was a really quick assessment that we were able to embed over the course of about a year within our clinic. We did do interviews and questionnaires of providers, leadership, medical assistants, and patients, all of whom felt this really had minimal impact on their workflow, didn't add extra time. We were surprised that people found stopwatches and lasers both equally as usable and didn't necessarily have a preference for one or the other. The medical assistants really thought the only barrier was the cognitive load and remembering to do this. And providers did feel that it had a high value potential, but they did have a little bit of uncertainty kind of how to direct people in what they should use for cutoffs. But I think this is a potential easy measure of frailty that could be included in other clinics, and I presented as an example of that. So once we have this measure of frailty or physical function, depending on what really works best in your setting, how do you use this information? What do we do with this? Well, I think having a measure of gait speed provides us with an opportunity, or a measure of frailty provides us with an opportunity to intervene early and really emphasize prevention. If I see someone has a slightly slow gait speed, I can talk to them about the importance of exercise, the importance of physical activity, of strengthening activities, of social engagement, and really emphasize this as, I see these early impairments and I want to keep you from developing frailty. So how can we intervene early? We can also look at reversible causes. Are there medications that might be causing and contributing to this? It could help us inform some decisions about how aggressive we are with care. If we have someone who has a gait speed of 0.5 meters per second, maybe only has a couple years of life left, we don't need to be quite as aggressive with treating their hemoglobin A1C and their blood pressure. Whereas that person who's quite fit, that has a quick gait speed, we can be just as aggressive or as aggressive as we can to really focus on their cardiovascular disease prevention. I think these measures can also prompt a need for discussions about long-term care and really say, hey, I see that you're starting to decline. Do you have resources at home, or can we get you additional support at home? It's a really nice guideline that was published last year in the New England Journal by Ken Rockwood, who's of the Rockwood Frailty Index, that goes through kind of different things that we think about at different stages of frailty. So you can see fit on the left side, pre-frailty in the middle, and frailty on the right side. And as you can see across these, regardless of how frail someone is, the emphasis and the main treatment across all of these different categories is a focus on physical activity. Physical activity and diet, things that we heard with epigenetics. And I think this is probably one of the most important components for preventing the progression to frailty. When someone gets into pre-frail or frail state, we can think about other things like multidisciplinary interventions, reviewing medications, which we'll hear about a bit later in Dr. Farhadian's talk. Notably, most of these have not been studied in HIV, but I'm just going to briefly touch on a couple of things that we do know specifically in HIV. Our group's been particularly interested in the impact of exercise on physical function. We haven't focused on a particularly frail population, but in a prior study that we did have about 80% of our participants who were 50 or older who had pre-frailty, and that's shown in the kind of the green and the red color here on the bottom bars with people with HIV at the top. And we saw a nice decrease with supervised exercise in these pre-frailty components after 24 weeks of supervised exercise. Another study we recently completed of 16 weeks of exercise, and you can see similarly had about 49% who had either pre-frailty or frailty, that decreased to 31% with exercise. So the two things, or the one thing that we really know can help improve frailty is exercise. Other studies have shown similar effect. This was in an older population, 60 and older in Brazil, that similarly saw significant improvements in frailty components, such as time to rise from a chair and gait speed, and a similar increase in the proportion of individuals who were robust in a home-based exercise intervention just over 12 weeks in Brazil. Ideally, we would love to be able to say, here's this pill that will treat your frailty. But unfortunately, there are no approved pharmacologic therapies for people either with or without HIV to treat frailty. There's likely very limited improvement, in fact, in most treatments that we would give someone, pharmacologic treatments, if they're not combined with exercise, because we really need that stimulus to help to improve muscle. We don't think that there's any negative effect of most antiretroviral therapy on exercise or on frailty, although we do know that not being on antiretroviral therapy is one of the most important risk factors for progression to frailty. And then there's certainly an interest in potential agents that might help to prevent progression to frailty. We looked at progression to frailty and impact on gait speed in the Reprieve trial with statins and didn't see any impact on statins. We've looked at the impact of semaglutide in the setting of HIV within the Slim Liver study. And although we did have a slight decrease in muscle mass, we actually saw an improvement in gait speed in that population, suggesting that in patients that are overweight and have metabolic dysfunction, some mild weight loss may be helpful for function. Testosterone has certainly been an interest, and although there's risk associated with testosterone in terms of cardiovascular disease, if someone has low testosterone combined with exercise, this potentially could help to improve physical function in select patients. And then there's a couple studies that are currently ongoing. A study that we're doing here in Colorado looking at tesamorelin as a treatment combined with exercise, and then an ACTG study that's looking at dasatinib and quercetin that just started enrolling last week. So with that, I just wanted to highlight there's still a lot of gaps in the field. We don't know the best tools for assessment. We don't know the best components that we might include in a multidisciplinary program other than exercise and nutrition to help improve frailty with HIV. But we do know that frailty reflects a vulnerability to stressors and probably occurs more commonly among people with HIV. A measure of function and frailty can inform patient-centered care and provide a target for interventions. And exercise really continues to remain the cornerstone for frailty prevention and treatment, both in people with and without HIV. And with that, I look forward to the question and answer session.
Thank you so much, Dr. Erlandson. That was wonderful. And I think it was enough to make us feel a little less frail. So as I wait for others to ask the questions, just one that I would like to start off with. What is the durability of these interventions that you're suggesting to against frailty, especially exercise? So somebody works out, maybe improved in that skill that you show, and then they stopped, they fall back off a cliff.
Yeah, I mean, I think there's probably some sustained improvement. Ideally, people can continue to exercise, at least some, and I think maintaining a certain level of activity is the way to continue to prevent progression to frailty. I think one thing we don't emphasize as much in our older adult population, particularly those with HIV, is the impact or the importance of strength training. And I think as physicians have often not to, I think our cardiology folks, especially, it's that exercise or walk, run, do anything you can cardiovascular wise and how important that is. But over the last probably 5 to 10 years, we've really begun to understand the importance of strength training, and that resistance training and strength training is probably one of the most important things. Unfortunately, muscle mass and muscle strength continue to decline with aging. And so unless we're keeping that up, some of the strength gains are probably lost over time. So I think that that's probably less durable, but some of the cardiovascular exercise, if people can maintain at least some activity, I think that will help to maintain some of their function over time.
Thank you so much. There's some interest, a lot of interest in whether you have published your study on the implementation of gait speed in the lasers in your clinic, and can you please post the study for information and
Yeah, we have
about the
not
lasers
published.
you purchased?
We have not published it yet. The geriatrician that I work with, that we worked on the project together, he presented it at the HIV and Aging workshop in October, and he is currently working on writing it up. So we'll hopefully have data published soon. But that's hot off the press data, has only been presented in abstract. We do have the laser device that's also installed in our seniors clinic here, and that's one of the reasons we were interested in it. But I will say that the good old stopwatch worked just as well and is much cheaper. And it took about 6 months to actually get the laser device installed. So for those of you who want something quick and easy, that stopwatch is a great assessment that's cheap and easy.
We feel very privileged to have you share that hot off the press study. Now, what type of exercise and how much exercise do you recommend to those you identified being high risk for frailty?
Yeah. I mean, I think that our guidelines suggest, the typical 150 minutes of moderate to
Mhm.
intensity exercise. I think anything is better than nothing. Trying to start at something that's doable. And I think that's, again, kind of like the vaccines. We don't want to overwhelm patients, but starting with can you get people to do 5 minutes a day? Can you get them to gradually start to increase that? We targeted in our intervention, we had people by the end of the intervention, they were exercising about 45 minutes 3 days a week. So we
Mm,
tried to have it kind of in supervised sessions in our gym. But I think if
mm,
people could get in a walk 20 to 30 minutes per day, that is a great way to help prevent some of these declines. Again, I think the importance of resistance exercise comes in there too. And the more that we can get people to focus on preserving muscle and really focusing
yeah.
on strength is just as important. It probably at least 2 to 3 days a week, plus some flexibility and stretching to help prevent some of those aches and pains that make exercise harder as we get older.
Just a little follow-up on that question.
Mhm,
A couple of years ago, there was some concern that with GLP-1 receptor agonists, we're
mhm,
losing muscle mass as well
mhm.
as fat mass. But but maybe that is something that has worsened over time, or is that
Yeah.
something that, what do you advise people?
Yeah, I think with any weight loss, we'll see a loss in muscle unless there's concomitant resistance training to really overcome that. When we
Mhm,
focus just on exercise, we see a weight loss, but we actually have an increase in muscle because we're not getting we're kind of shifting body composition, but not really focusing on a massive a
mhm,
big weight
mhm,
loss like we see with GLPs.
mhm,
With that rapid weight loss we see at GLPs, there definitely is a loss in lean mass or muscle, probably about 5 to 10%. And
mhm,
that'll probably be even greater when we're using these more potent therapies.
mhm,
I think, especially over time, when someone stops the therapy, they may see a rebound in their weight, but they're not going to get that rebound in lean mass. So, kind of this cycling effect that we might see with GLPs may cause even more lean mass loss. So, certainly in our patients that have metabolic dysfunction or diabetes or
mhm.
take GLPs for weight loss, really emphasizing the importance of resistance training, I think, is
Yeah,
incredibly important. And then making sure people are getting adequate protein, especially
excellent.
if people don't have as much appetite or maybe don't have as much of an appetite
Mhm.
for higher protein foods, it's harder to keep up with those protein needs that they probably need in the setting of the weight loss drugs.
Excellent, thank you. Some remind us, it's a question, is mental health and depression a factor of frailty risk?
Yeah, I think both are definitely important components. Some frailty indices will include measures of mental health, and some think that that's kind of just something that is related to it. But in almost every study, we see a strong association between depression, as well as cognitive function and frailty. So definitely an important part of that.
Mhm. All right, so I think this is probably all the questions that we have, and I'd like to thank you again for a terrific presentation on frailty. I think it's time for all of us to hit the gym after Dr. Erlandson's talk, and then I'll send it back over to you.